Dr. Andrea, many patients see the pain specialist almost like the intensivist of pain, the doctor they turn to when nothing else has worked. How can we improve the way we treat this patient?
Well, the problem has been that pain management has always been this treatment of last resort. When all else fails, send them to pain management. And unfortunately, that's a little like sending a diabetic patient to an endocrinologist only after they've developed gangrene and then being surprised that the patient doesn't do well because the damage is already done. So in our case, they've already had multiple back surgeries that didn't do better, or they've become so debilitated that they can't do the things. Even if I could wave a magic wand and get them better, they can't do what they used to be able to do. And so I strongly believe that we need to see these patients early. We need to see them before they see the surgeon. I've never understood why when somebody has low back pain, the primary care doctor sends them to physical therapy for 6 weeks. And when they don't get better, I think that's just temporizing, hoping they'll get better in 6 weeks and they don't have to deal with it. But the physical therapist, because they don't know why they have the low back pain, does a little bit for facets and a little bit for disc and a little bit for SI, none of which is enough to help the actual problem, and some of which counteracts what they were trying to do. You know, treatment of a physical therapy treatment of a disc is different than the physical therapy treatment of an SI, and if you don't know which is which, you're just putting them through the very generic exercises. So when they don't get better from that, then they get an MRI, and if the MRI shows anything, one bulging disc, off they go to the surgeon. And the surgeon says, well, either, come back and see me when you can't walk. That makes no sense to me. So instead, I think that we need to be sending patients to the pain doctor early. So if I have chest pain, unless I'm having an acute MI, you don't send me to the cardiothoracic surgeon. You send me to the cardiologist, and the cardiologist does the physical exam, does the diagnostic studies, puts me on the appropriate medicines, does the more invasive studies if it's a problem like a MUGA, does then the cardiac catheterization that identifies the problem, does the minimally invasive surgery of a stent to open up that blood vessel, and it's if and only if you've got a documented surgical lesion and you failed those modalities that you ever go to see the cardiothoracic surgeon. At that point, 99% of those patients are surgery candidates. Instead, we send them to the surgeon without a good diagnosis, and the surgeon is looking at the MRI going, well, you see there's that bulging disc. And they're not paying attention to the fact that Jensen's study in July 1994, they took 98 asymptomatic patients who'd never had back pain in their entire life, stuck them in the MRI scanner, and 60% of them had herniated or bulging discs. They had spinal stenosis, they had spondylolisthesis, they had facet pathology. All those things we think cause pain, they were asymptomatic, but when they showed those films to surgeons, 40% of those MRIs were offered surgery. So patient gets a surgery for something that's not causing them pain, can't possibly get them better. So we've got to be working with our primary care doctors early. Send them to me before you start them on the inappropriate medicines. Let me make the diagnosis. If we can get them back functioning early, then you can actually get them healed. Don't wait till the last minute.
Amazing. Thank you.